We often picture doctors with stethoscopes and white coats, but a huge part of their job, maybe the most important part, is acting like a detective, trying to crack a case where the clues are hidden and the stakes are incredibly high. So that's the big question, right? How do they solve a medical mystery when all the clues are tucked away inside the human body? A patient can tell you what they're feeling, sure, but the real evidence, the reason why they're feeling that way, that's a whole other puzzle. And that's how they do it. They put on their detective hat. So today, that's what we're going to do. We're going to open up two real case files and follow the evidence step by step to see how these medical mysteries get solved. All right, let's open our first case file. We'll call this one the Jaundice Puzzle. It starts with a 60-year-old man, and while his symptoms are pretty clear, the actual cause, well, that's a total mystery. Okay, so here are the initial clues we're working with. He's got jaundice. That's when your skin and eyes turn yellow. He's also got dark urine, pale stools, some really bad itching, and he's lost a fair bit of weight without trying. Now, to a medical detective, these clues are all pointing to one general area. Something is definitely wrong with the liver or the bile ducts, the plumbing system that connects it all. So, we've identified the crime scene, so to speak. It's in the biliary system. But what's actually happening? We need more than just the patient's story. It's time to call in the forensics team and get some hard physical evidence. And here we go, our first piece of hard evidence from the lab. And wow, just look at these numbers. The bilirubin, which is what causes the yellow skin, is way up. But look at the alkaline phosphatase and the GGT. They are off the charts. This specific pattern is a giant, flashing neon sign for a detective. It screams obstructive jaundice, which means something is physically blocking the flow of bile. It's like a clogged drain. So what's next? You get eyes on the scene. An abdominal ultrasound gives us our first look inside, and boom, it reveals a dilated common bile duct. That means the main pipe is stretched out and swollen because of a backup. This confirms what the labs were telling us. We have a blockage. It's a real physical problem. Okay, now that we have the initial clues and the forensic evidence, our detective, the doctor, can start lining up the usual suspects. In medicine, they call this a differential diagnosis. It's basically a list of all the things that could be causing the problem. Let's look at suspect number 1, pancreatic cancer. It's definitely capable of causing a blockage like this. But the evidence doesn't quite fit. Usually, it comes with a lot of pain, and you'd expect to see a mass on the ultrasound. Our patient has no significant pain, and the ultrasound was clear. So the alibi checks out. Pancreatic cancer is off the list. All right, next suspect, hepatitis C. Now, this is a viral infection that attacks the liver, but it doesn't cause a physical blockage in the bile ducts. And all of our evidence, the labs, the ultrasound, it all points to a physical obstruction. So hepatitis C just doesn't fit the facts of this case. So what about gallstones? They're a super common cause of blockages. But again, the story just doesn't add up. When a gallstone causes a blockage, it usually brings on this really severe, specific kind of pain. Our patient doesn't have that pain. Plus, the ultrasound saw no stones. So we can rule that one out too. So after crossing off all the other major suspects, we're left with the one culprit that fits every single piece of evidence perfectly. Primary sclerosing cholangitis, or PSC. It's a chronic disease where inflammation and scarring slowly choke the bile ducts from the inside. It explains the slow progressive jaundice without much pain, it explains the lab results, and it explains the dilated duct. It's a perfect match. Case closed. Now for our second case file. The whole scene is different here. The clues are way more urgent, but you'll see the detective's process is exactly the same. This time, our patient is a 45-year-old woman, and she is in a lot of trouble. Okay, the initial report is intense. We're talking severe pain right in the upper middle part of her stomach, and it's shooting straight through to her back. She's got a fever, she's nauseous, and here's a key clue. It all started right after a big meal. When the doctor examines her, her abdomen is incredibly tender. This is a very acute situation that's developing fast. The lab results come back, and they are nothing short of dramatic. Amylase and lipase, these are digestive enzymes that are supposed to stay inside the pancreas. When you see them in the blood at levels this high, it's a massive red flag. It means the pancreas is so inflamed that it's actually leaking. The high white blood cell count just confirms the body is in the middle of a major fight. I just want to pause on this number for a second. Lipase at 800. The normal range tops out around 300. This isn't just a little high, it's astronomical. In any medical investigation, this is what you call the smoking gun. It points the finger squarely at one specific organ. And the imaging backs it up completely. The ultrasound shows the pancreas is swollen and inflamed. You can even see this thing called fat stranding around it, which is basically a visual sign of all that inflammation. And just as important, the ultrasound confirms there are no gallstones, so they aren't the cause. So we can very quickly rule out the most likely alternative, which would be acute cholecystitis, a gallbladder inflammation. Why? Well, the pain is in the wrong spot. And more importantly, there are no gallstones. The evidence just isn't there. With this mountain of evidence, the diagnosis is clear as day. It's a slam dunk. This is acute pancreatitis. The intense pain, the fever, the story of it starting after a meal, and especially those crazy high enzyme levels, it's the absolute textbook presentation. Mystery solved. So, after cracking two very different cases, what did we learn about how a medical detective works? It's not about a lucky guess or some kind of magic. It is a system, a process. And this is pretty much the playbook. First, you gather the clues. That's listening to the patient's story and the physical exam. Second, you collect the hard evidence, your labs and your scans. Third, you use all that data to identify your list of suspects. And finally, fourth, you crack the case by meticulously going through that list and finding the one single explanation that fits every last piece of the puzzle. You know, it all reminds me of this quote from Voltaire. It's a good reminder that while we can get caught up in the fascinating puzzle of diagnosis, the real point is to support the person while their body does the hard work of healing. It's a blend of science and art. And that kind of brings us to one last question to chew on. In our world of MRIs and genetic testing and all this incredible technology, what's still the doctor's most powerful tool for figuring things out? As we saw today, it might just be the oldest one in the book, the human mind, carefully and logically putting the pieces together. Something to think about.